So Alyssa and I are kind of dividing and conquering this last presentation just because it's got more meat and potatoes to it. We're going to be talking about the intrapartum use of magnesium. So just kind of highlighting the different things that we talked about. So we've gone over the intrapartum management of GDM, as well as managing insulin drips, and then also talking hypertensives, kind of background, as well as intrapartum management for both. And now we'll specifically be talking about magnesium management. So just a quick review. So I think we all know this, but we need to emergently treat blood pressures greater than or equal to 160 over 110 with antihypertensives when patients are in the hospital. The order set for this is the emergency therapy for acute onset severe hypertension obstetrics. You can also type in OB hypertension, and this will show up as well if you go into your order sets. IV labetalol versus IV hydralazine versus PO nifedipine immediate release are all your different options for this. And there's some really good algorithms listed in the SharePoint drive, as well as the patient care bulletin from Meritor that we emailed out with the slides from last time. There's also copies of the algorithm for the antihypertensives at the bedside in each room as well. So we are going to talk about magnesium, the overview, as well as its indications. We're going to talk about the hospital protocols. Alyssa will talk about documentation. She's done some really awesome work with kind of collating document resources and smart phrases for us as a family med department. And hopefully we'll have some time for a Q&A session. So I don't think this is much of a surprise for anyone, but MAG is ACOG level A evidence in terms of being used for the prevention and treatment of seizures in women with preeclampsia with severe features or eclampsia. There was the MAGPIE study that was done, gosh, it's been, I think, some time. It was a randomized placebo-controlled trial. They actually were able to enroll, it was a global study, 10,110 participants. 2/3 of those were actually in low-resource countries. They essentially found that the seizure rate of folks that had preeclampsia with severe features was lower by 50% with this treatment. Interestingly, in more developed countries in the West, they did not notice a significant reduction in the rates of developing eclampsia. Using that MAGPIE trial, they then did a systematic review of multiple trials that showed that the use of mag sulfate significantly halved risk of eclampsia, as well as reduced risk of placental abruption. It did non-significantly reduce risk of maternal mortality, but it did increase the risk of C-section by 5%, and that's something that we'll talk about in counseling for our patients. Move forward. And so just other kind of quick things about magnesium. It basically works by relaxing smooth muscles. It's definitely superior compared to benzodiazepines or phenytoin. For prevention of seizures and eclampsia, it's just important to keep in mind that this is not something that will lower blood pressure. It's really used for seizure prevention. So thinking about using your antihypertensives to lower blood pressure acutely. There are some instances where magnesium is contraindicated. So if a patient has myasthenia gravis, they have cardiac ischemia, heart block, some cardiac conduction issues, that's where you may want to consider using phenytoin or benzodiazepines, and we're not going to be managing those patients. That would definitely be, I feel like, under OB's purview anyway. Interestingly, the risk of seizure without treatment is 1.6%, and that's part of the counseling that we provide when we're talking to patients about initiating magnesium. And so it's one of the reasons why the benefits outweigh the risks. Alyssa has kindly created a list of smart phrases. This counseling for a patient that you're starting magnesium on is going to be under .fmob mag counsel. Alyssa, I think you shared with myself and Allie, I think, is that right?
Yeah, and Jency as well as owners.
And Jency, cool.
Many of those folks.
Exactly. And so the counseling basically talks about, if someone has preeclampsia with severe features or, God forbid, eclampsia, magnesium has been shown to prevent seizures in preeclampsia with severe features. It helps prevent adverse maternal outcomes like placental abruption, maternal mortality, all the things that we get worried about. And that the risk of seizures without MAG is 1.6%, but there is, a slightly increased C-section rate for patients that are on MAG. So that's kind of a general overview, and you can definitely check out this smart phrase to look at that counseling more in detail.
Okay, so just talking about magnesium dosing, hopefully this is kind of a review for some of us from like what we've learned in also courses. There's a table on the right-hand side, which is drawn from the ACOG Bulletin. The therapeutic range for magnesium to prevent an eclamptic seizure is roughly between 5 to 9 milligrams per deciliter. And above that, we start to get into a realm of toxicity, which we'll talk about the signs of. Generally, magnesium is given as a loading dose followed by a maintenance rate for folks who have normal renal function. That loading dose is usually given as 4 to 6 grams IV loading dose. I remember from also that like 6 was always on in my mind. And I have just seen a little bit more commonly at Meritor, people giving 4 grams or the nurses kind of prompting to be like, are you sure you want to give 6? Give 4. So that I feel like is what I have seen, but either dose is appropriate based on the ACOG guidelines. And then generally the continuous infusion is 2 grams per hour following that. The caveat being that if someone has renal insufficiency, let's say a creatinine that's double what their baseline was or greater than 1.1, that we would want to kind of have that maintenance dose to 1 gram per hour. And the other option in some cases is to actually not give a maintenance rate at all if we're really worried about the progression towards super therapeutic or toxic levels of MAG. Then sometimes you're basing things less off of symptoms of toxicity, more checking magnesium serum levels and giving bolus dosing as opposed to a continuous rate. So sometimes what you'll see is that someone will give an additional 2-gram bolus, 2 hours later. The caveat with that being, and we'll talk about that in a moment, that probably if we're getting into the realm of significant renal insufficiency where we're worried about progression towards toxicity, this might be a case where, or it would likely be a case where we get someone from OB involved because it's not kind of a straightforward management of magnesium per the protocol. But just know that 4 to 6 grams loading and 2 grams per hour maintenance is generally what we'll be placing in terms of order. In terms of signs of toxicity, that can be progressive based off of the serum concentration. So the first thing that we'll often see is loss of deep tendon reflexes. You see that on that table on the side here. Often then can progress to respiratory depression. And then finally cardiac arrest, which is the absolute do not get to that point toxicity level, which I think we can all recognize. But outside of those toxicity effects, there are just some adverse side effects that folks will experience while on this medication, some flushing, some warmth. They might feel nauseous. They have some degree of muscle weakness, headaches. Generally, patients are not ambulatory when they're on magnesium just due to kind of feeling so unwell and perhaps some of this muscle weakness as well, just to keep them safe. And then we'll talk more about the increased risk of postpartum hemorrhage and atony in a future slide as well. For patients who are, so we're thinking about kind of patients who seize, who if folks are not already on magnesium and this is the first onset seizure, then we're going to be starting magnesium per the usual protocol. So a 4 to 6 gram loading dose and then starting a maintenance rate. So kind of beginning management for preeclampsia with severe features with magnesium at that time if this was a seizure when someone was not already on magnesium. However, if someone seizes and they are already on MAG, then the first line treatment is not a benzo as an abortive treatment. It's another bolus of magnesium. So that's the most important thing to remember is that an additional 2 gram bolus is the treatment of choice. If the patient continues to seize, then usually a benzodiazepine, something short acting like lorazepam or midazolam, is generally the next step. And there is a table we'll talk about. There's like a Meritor document that outlines all of these protocols for the management of magnesium. And at the very kind of towards the bottom of that document, there's a table that goes over all of the abortive options for seizures in patients who are already on magnesium and have received that additional 2 gram bolus dose. So know that there is a resource that you can go to. You don't need to memorize that, but just remember kind of first line option is always an additional 2 gram bolus if they're already on MAG, and then you can use a short acting benzo. And usually at that point, if someone is still seizing 5 to 10 minutes later and they're on magnesium, we're going to have other folks, other teams involved in the care at that time as well. So you'll have other resources at your disposal. Next slide, please.
So next we're going to kind of talk about magnesium checks and what those entail in terms of both like the clinical, aspect as well as documentation aspect. So the first thing we wanted to talk about was when do you actually check mag levels? So for most patients, actually, we don't routinely check them as part of monitor or having someone on magnesium sulfate therapy. Reasons to check a mag level, obviously if a seizure occurs, you're trying to look and see if you're subtherapeutic when it comes to that mag level. If someone has renal insufficiency, and like Alyssa alluded to, we're probably not going to be taking care of these patients, to be honest. It's probably going to be OB and MFM that will be involved. But certainly if someone has renal insufficiency, you're going to want to check those levels more frequently. And then certainly if someone has signs or symptoms of magnesium toxicity, you're going to want to check a serum level. In terms of what kind of makes up a magnesium check from like a clinical standpoint, per Merida protocol for patients that are on magnesium, the RN needs to do a clinical evaluation every 2 hours and document this. So they're assessing any symptoms, so your typical, headaches, right upper quadrant pain, chest pain, shortness of breath. They need to do a CV and a palm exam, check edema, check grip strength, check patellar and Achilles reflexes, check for clonus, and then also document urine output. So the nice way to kind of see all of this in summary in the RN documentation is that if you go to flow sheets, and then there's a tab called labor. And so that actually has all of the objective data for these various clinical findings that the RNs document. In terms of urine output, I have here a goal should be greater at least 30 mils per hour, and that's over 4 hours. They should average out 30 mils per hour. If they're not meeting that criteria, we get concerned about oliguria, and that could be something to prompt us maybe checking a level or checking electrolytes and kidney function and that sort of thing. Let me move on next. Alyssa, you were going to talk about this, right?
Yeah. So the Magnesium Intrapartum documentation. So we know that the nurses are kind of doing a lot of this documentation within a flow sheet, but knowing that we're also writing labor progress notes fairly frequently, what I've seen is generally that a progress note that reflects the magnesium management every 4 hours is generally what's expected. So certainly we sometimes in active labor are doing Q2 hour notes, but every 4 hours should at least be doing some degree of assessment to look at kind of the management, particularly as it pertains to magnesium. I created a dot phrase that's .fmob mag labor, and the things that it has in it, I stole that also, want to attribute the OB colleagues of being the kind of, I stole that template from someone and then modified to some of our needs. But the objective data that's documented should include vital signs and then has a bit more of a thorough exam, including a cardiopulmonary exam and a neurologic exam. And then also puts in notes about the maintenance dose of magnesium that the patient is currently on, as well as their hourly urine output over the last 4 hours. And again, that can either be from the RN flow sheet, that's flow sheets labor, like that Lashika was talking about before, or the IO flow sheet that we just kind of could standard use for any ins and outs is also updated hourly. And then the assessment and plan prompts several things, including like what we're doing for blood pressure at the time, what we're doing in terms of magnesium, in terms of the maintenance dose, if there's any concerns about toxicity, if there's been any seizures, if urine output is adequate. And then I have a couple other things in there about like fluid restriction and diet, just as prompting, just so that we kind of remember a couple other aspects of this care, especially as we're introducing that into our care team. So that dot phrase again is shared with Lashika, Jency, and Allie, and we'll make sure that they kind of all agree that that's an appropriate dot phrase to use, and then you can feel free to steal from any one of them. I think we're ready for next slide.
So these are a couple screenshots of the order set for magnesium, and so it's titled OB Magnesium Sulfate. And so the things that I've clicked, there's no like pharmacist specific order sets. You'll have to make sure that you select certain things. So for example, selecting the calcium gluconate, just having that available in case you're concerned about toxicity, so it's easily available. You're seeing here neuroprotection, tocolysis, and preeclampsia. Those are the 3 indications for magnesium. And so you have to click on the arrow or click on magnesium for preeclampsia to kind of open up that menu. And so clicking on the button for IP magnesium sulfate for preeclampsia panel, here it talks about the IV fluid restriction, which we'll talk about kind of in a later slide. It has seizure precautions pre-selected. And then here you can see that you need to click on the loading dose. It's listed as 6 grams as part of the order set. However, like Alyssa said, a lot of times nurses will prompt us to change that to 4 grams. And that seems to be more of the practice at Merida. you have the option for doing IM MAG if someone does not have IV access and they're seizing and you need to get MAG in more urgently. And then you do have to select the maintenance dose of 2 grams per hour. So notably, you have to click on the loading and the infusion dose. The next part of the order set talks about corticosteroids, and it's really nice because it has kind of the various indications for steroids, including the more recent recommendations for maybe a single course of betamethasone between 34 and 37 weeks. So that is an option that you can click on and consider depending on your patient's gestational age and what's going on. Vital signs are per unit routine. When I was looking at that, typically when someone is getting a loading dose of MAG, the nurse is going to be at the bedside checking vitals every 15 minutes times 4. Then after that, they'll do every 30 minutes in the second hour. And then if someone has severe features, they're going to be doing vitals every 30 minutes while they're on MAG. Certainly they need to be on continuous pulse ox, just because you get concerned about respiratory depression with MAG toxicity. So that's going to be something that needs to be done. And then just routine checking temperatures. I think we skipped diet and nutrition. Usually it's clear liquids or NPO, depending on where they're at. In terms of I's and O's, that's usually per unit routine. Patients are going to have a Foley catheter once they're on MAG, and so that's helpful for accurate urine output. Assessing level of consciousness, so these are the things that the nurses check with their clinical assessments, grip strength headache that we talked about, and then just some stuff about assessing magnesium toxicity, magnesium infusion management. There's the bladder management underneath, usually pre-selecting, Foley insertion and maintaining. These patients are obviously going to be on continuous external fetal monitoring. They will be on bed rest and just kind of a fall risk and a seizure risk. So they have those sorts of precautions. And then, the usual stuff of notifying a physician, but for magnesium specifically, you'll be notified if the urine output is less than 30 mils per hour, if they have, a respiratory rate less than 12, if they're having decrease in their tendon reflexes or level of consciousness, in addition to the usual things that we typically get notified about. And then the last thing is that it does offer options to schedule magnesium checks. I often would recommend clicking the PRN option, because that way a nurse can, if they are concerned about toxicity, they can just order it so we can get a level faster. But again, like we talked about, there's no need to do like routine scheduled magnesium serum checks.
So kind of considerations on MAG, and that these are often were reflected in a lot of those boxes that Lashika just went through in the order set. So the fluid restriction, generally, that will be a discussion between the provider and the nursing team, but the standard is generally 150 cc's an hour of total fluid intake, and usually 125 cc's of that is IV, knowing that often sometimes these patients are both on magnesium as well as potentially on Pitocin as well. Most patients will be on either clear liquids or NPO, and that can be at provider discretion or depending on where they are in their labor course or their concern for a need for an emergent surgery. But generally 150 cc's an hour is the kind of limit, and can always back off on that if you're concerned at all about someone nearing volume overload. So we know that severe preeclampsia is also a state of increased capillary permeability. The risk of pulmonary edema is high. So certainly if you have any concerns that someone's trending or is third spacing much more of the fluid that they're getting in than they should, then you probably want to restrict their fluids a little bit more and see what you can concentrate in order to not risk any degree of respiratory compromise. We know that Foley catheters generally placed in order to maintain accurate I's and O's. I have seen one patient who declined this in the past, and I think didn't have an epidural at that time, and so she just used a bedpan at the bedside, and so the nurse was really good about just trying to have her urinate at least every 2 hours if possible, but I think later on in her labor course she ended up getting an epidural and a Foley at that time. Bed rest with SCDs is standard for everyone, and then we already talked about the continuous monitoring. Patients are not on telemetry, but we're able to monitor both their respiratory rate and their heart rate with a continuous pulse ox, or at least we're getting a sense of how their cardiorespiratory status is. And then regarding the increased postpartum hemorrhage risk, that's important to know. The thought with this is that there's an increased risk of atony due to magnesium's effect on smooth muscle tone. And so certainly if a patient has not had a type-in screen on file, making sure that they have a type-in screen and a CBC is important. And then, knowing our kind of postpartum hemorrhage risk algorithms, that sometimes you can have a cumulative effect that point someone more towards a high risk postpartum hemorrhage or a higher risk postpartum hemorrhage status. So if a patient is appropriate for typing in crossing for 2 units, it's important to consider that. So that kind of adds to some degree of concern in terms of how high your suspicion is for a postpartum hemorrhage. Next slide. And then consultations. So the goal with this, my understanding, or at least of the goal with this, is that we would still be doing an OB consult at the initial diagnosis, just to make sure that kind of OB is aware and that we're getting some degree of management recommendations for the management of severe preeclampsia. However, the goal with this training is to have the family medicine team continue to manage as the primary providers for our patients while managing magnesium and antihypertensives, et cetera. But goals should be to consider transfer of care if there's any concern about worsening clinical status or something that feels outside our realm of comfort. So end organ damage, concerns about progressive magnesium toxicity that's not responding to a decrease in their rate of magnesium infusion. If there's any concern about a progressive clinical picture, really any of those things might prompt us to transfer care as opposed to just do a consultation to OB. Anesthesia consult is another one that can be important to consider. And so that kind of goes beyond just kind of asking them to weigh in on epidural timing and discussing epidural with patients, but knowing that they might need to be prepared for more emergent deliveries. They might be more involved in assessing a patient's airway if they're concerned about that, and that some of these patients in more extreme states of severe preeclampsia can have thrombocytopenia, and that may affect their risk when it comes to neuroaxial analgesia. So just important to thinking about how they should be counseled and potentially counseled ahead of time as opposed to emergently. And then magnesium in severe preeclampsia automatically qualifies the patient for a C2 delivery, but if there isn't any concern based on gestational age or other factors, just getting NICU involved. Wow.
So, postpartum course, we typically tend to continue magnesium sulfate until 24 hours postpartum, obviously due to, respiratory depression. We try to avoid opioids while on magnesium. Typically, this, at least for my Thursday mornings, has been very provider dependent from the OBs, but Alyssa and I were talking, and I think for us, especially as we're starting out as a department, it's probably best to protocolize things like, getting labs. And so we were thinking getting daily labs until 2 sets are normal or trending to normal would be appropriate. Or obviously you can get them as needed if there's any concerns. Typically blood pressure checks are every 2 hours while on mag sulfate. And then certainly these patients probably should have some sort of blood pressure monitoring for 3 days postpartum. If someone's having persistently severe range pressures, they should probably be on an oral antihypertensive, which we can initiate in the postpartum period. There's not really consensus on treatment of like mild to moderate range blood pressures in someone who has a diagnosis of preeclampsia with severe features, but definitely if they're having persistent severe range features, they should be on an antihypertensive. Anticipatory guidance is going to be really important for these patients because they can certainly have recurrence of, pre-E with severe features postpartum. There's an increased risk of developing peripartum cardiomyopathy. And so those are things that should be discussed with patients when they're ready to go home. And then certainly having very close follow-up in clinic within a week of discharge, just to check in about blood pressure, check in on symptoms, probably would be recommended.
And just for postpartum documentation, so typically we're just doing daily progress notes for patients who are postpartum, but in this case, we are still doing every 4-hour notes while patients are on magnesium. So that kind of still continues to carry forward as long as the MAG is on board. And so I, again, created a dot phrase, it's .fmob MAG postpartum. And includes many of the same pieces. The only thing that I think is additional there is that there's kind of clear documentation about when MAG is anticipated to be discontinued. And then otherwise it's pretty much the same and just has removed like the labor management piece of these. So knowing that these dot phrases are available, I think the one other caveat is that they're really just geared towards the management of preeclampsia with severe features and may not have all of the other complicating factors or other things that we need to be aware of when we're documenting for patients. So kind of flushing out the note fully in order to kind of reflect what other items are going on in the patient's pregnancy. I think this one says like continue routine postpartum care, but if there are other aspects of their postpartum care that are not quite routine, it's still important for us to make sure that we document that. And so certainly any feedback about how to make that more to correspond more with kind of our current note structure, I'm happy to make adjustments.
And so we will definitely send out with these slides the married or patient care policy. It's number 35 that's specific to magnesium sulfate therapy. And then we'll also send the updated ACOG bulletin for gestational hypertension and preeclampsia that has some info on MAG. But hopefully there's time for maybe questions or discussion, and we're happy to chat offline with folks as well too.